Going to wait for another. Good morning, everyone. We're just going to wait for maybe another minute before we start the session. Oh, actually, it's 10:01, so we can start the session. So, hello, my name is Sheila, and I'm the Allied Health Engagement Officer at CHN. Thank you for taking the time to attend today's briefing session on the Multidisciplinary Approach to Diabetes Care Pilot Program. Now, we'll start with a presentation about the program, and there'll be an opportunity to ask questions via chat afterwards. This session is recorded, and it will be available to all the attendees and on the corresponding tenders page. Now, before we begin, we'd like to acknowledge the Ngunnawal people as traditional custodians of the land on which we meet today and pay our respects to elders past, present, and emerging. We also extend that respect to the elders of the land you are joining us from today and any First Nations people who are present. So what is this tender opportunity about? As part of strengthening Medicare measures, CHN received funding from the Australian Department of Health and Aged Care to commission a multidisciplinary care team from allied health professionals, nurse practitioners, nurses, midwives, or Aboriginal health workers or practitioners. This is meant to support small or solo general practices and Aboriginal community-controlled health services to improve the health of underserved patients. Now, in terms of the grant guidelines, the objectives are to design an approach for multidisciplinary team services in the ACT through consultation with small or solo general practices, or the ACCHS, that are unable to engage a multidisciplinary team through other funding streams. Identification of priority areas of need, that is the chronic disease in underserved or financially disadvantaged communities. Commissioning a multidisciplinary team with a focus on supporting smaller practices that do not have the size or scale to engage the full range of health professionals required to provide effective MDT care. Extending the PHN's existing role in general practice to support private allied health providers, nursing, and etc. Establishing reporting processes supported by data collection and data management practices, including activity and outcome measures, and this is where the PROMs and PREMs come in, and monitoring implementation of the activity, utilizing relevant outcome measures and developing adjustments to the approach if required, and this is where the co-design review of the model comes in. Now, why diabetes? Looking at the CHN needs assessment in 2021 to 24 and data from the ABS census of the same year, it shows that there is a need to support diabetes in the ACT, considering the prevalence and the reported mortality rate. At that time, the prevalence was 33.9% in the territory, which was the highest in the country compared at the national rate of 23.8%. So what is this program about? Now, the MADC program aims to provide free access to a multidisciplinary care team for adults at risk of developing complications associated with diabetes through their local general practice or ACCHS in the ACT. Now, in terms of the scope of activities, the program is available to eligible adults diagnosed with diabetes who are motivated to participate and engage with the program and to whom MDT care would be beneficial. Now, the funding, some things that are out of scope of the funding would be children with diabetes, gestational diabetes, existing health or medical programs that are already in place through ACT Health Diabetes Services, funding for social support or recreational activities provided by available providers in the territory, and funding for disability support services that's already covered under NDIS. Now, in terms of the program, the key stakeholders are the small or solo general practice, or the ACCHS, and here basically, we are looking to have a geographical spread, one in the north, one in the south, and one ACCHS. The GPs and a practice nurse are expected to be involved in the selection and triage of patients to refer into the program. There will be some care coordination involving the practices. And for allied health services, we'll be commissioning one team composed of an accredited practicing dietitian, a podiatrist, and an exercise physiologist or physiotherapist who will be providing services to the selected practices on diabetes clinic days. Now, CHN will pay the providers for service delivery, administration, and transportation, and MBS items will be utilized where possible. The program funding should cover any shortfalls within the agreed number of appointments. Now, the services within the program will be free for the patients, as mentioned earlier, and that includes at baseline, an initial assessment, and a follow-up appointment. Further appointments or group sessions that utilize MBS items will be discussed with the selected providers during the co-design review. Now, we'll also be working with a diabetes educator who is not a part of this EOI. Now, as you can see in this diagram, the practices will be selecting the patients for referral into the program, and the program will have clear entry and exit points. They will check for eligibility and triage the patients, and there will be HbA1c monitoring at practice level. Now, each practice will involve case coordination shared between the practices and allied health providers to assess the individual patient needs and to adjust supports accordingly. So as I mentioned earlier, there's a baseline model where there's an initial and a follow-up appointment, but there is room to have more allied health appointments with the enrolled patients. But again, that's a discussion that will be had at the co-design review among the practices and among the chosen allied health providers. Now, this approach allows for flexibility and ensures that patients receive the appropriate level of support that they need based on their needs and progress. And we see that, or we envision that this pilot will enhance cultural change in primary care through multidisciplinary team integration, through workforce efficiencies, and seeing health practitioners working to their full scope of practice, capacity building of clinicians and practice staff, and in ensuring that there are sustainability measures throughout the use of available resources. Now, in terms of where the program will be located, the idea is that there will be a diabetes clinic day at the general practice, or ACCHS. Now, what that looks like, the frequency or which days, again, this will be part of the discussion with the chosen providers. The commissioned allied health team will be delivering the services during those days, and things to consider include the physical space at the practice. As I guess, as an example, an accredited practicing dietitian could potentially be co-located at the practice on specified days. But considering equipment needed for podiatry and exercise interventions, this could potentially be located at an allied health practice, or for exercise, a gym or community center. Again, this is all up for discussion. Now, the finer details will be determined during the co-design review with all the practices and allied health providers. Now, here are some of the things that we will discuss during the co-design review. So as I said, we've got a baseline model of care that CHN developed through stakeholder consultation. We will present these ideas to the selected providers during the meeting to ensure that the model that we implement works for everyone. And here are some of the key requirements that you'll find in the service agreements. So first of all, service delivery, and that involves the appointments and multidisciplinary team care coordination, involvement in program meetings, and that would be the co-design reviews, team meetings, stakeholder meetings, meetings regarding the evaluation of the program. There will be training attendance as needed. So this is on an ad hoc basis. I mean, we offer these trainings at no cost to the provider. So this will be funded by CHN, separate to the service delivery arrangements. So available training courses could be care coordination, proms and prems, cultural safety, and any others that are identified during the program. Enrollment and triaging of patients happens at practice level. Care coordination between the practice nurse and allied health practitioners is something that would be required. And then communication with patients, including consent to participate in proms and prems. So at the start, this will be done at practice level. So the practices will inform the patients that in order to participate in the program or as part of participating in the program, there will be surveys taken at the start, at the middle, and towards the end of the program to see how what the outcomes are and how the program is helping them. And we expect that the allied health providers will also be in part of this conversation. Now, the evaluation activities that it states here, participation in surveys, this is mostly for the providers at practice and allied health providers. What this is basically to find out how we're implementing the program, things that we can improve, what's working, so the barriers and facilitators, so that we can develop the program over time for a model that works, something that's replicable in other chronic conditions, for example. Reporting, as a CHN will be providing templates for practice performance and financial acquittals. Normally this happens every 6 months. So the submissions are every 6 months. And monthly invoicing, so we can have a conversation about this. If you become a selected provider, we can definitely go through this. And as for stakeholders, so we've got the funders, the Department of Health and Aged Care, Capital Health Network, the Allied Health Professions Australia. They were involved in a workshop in terms of the discussions on the baseline model of care, and they will be involved in future discussions as well. General practices and the ACCHS, and of course the selected allied health providers and the patients. We will also be closely liaising with the ACT Chief Allied Health Office, the respective peak bodies, and Canberra Health Services, in particular the diabetes services and community care centres. And we also hope to work with allied health student clinics in the ACT and the Healthcare Consumers Association. Now, dates to remember. So the EOI closes on the 24th of February, and that's at 5 p.m. We will be reviewing the expressions of interest soon after, and we will be notifying the successful applicants, or the applicants rather, of the outcome, and that's on the 6th of March, and that's for practices and all allied health providers. If you are notified of the outcome, you will also be, if successful, you will also be requested to submit a proposal, so the RFP opens on the same date. RFP closes on the 24th of March, 2025. So I guess that gives us about 3 weeks. The submissions for the review of submissions for allied health will be towards the end of March. And we expect that we will know who the successful providers are in early April. And the contracts will be signed, or the service orders will be signed towards maybe mid to late April, and onboarding will immediately commence. Services are expected to commence sometime in May. Given the timings now, I expect that this would be towards the mid to end May, but again, this is up for discussion. And the project, as of the moment, the timeline that we have is up to the 30th of June, 2027. Now, successful applicants, as I said, will be notified via email and invited to submit further details via a request for proposal. And some tips, if you get to this stage, please keep your answers concise and within the word count. Attachments are not accepted unless specified in the questions. And if you have any questions, please submit them via email to tenders@chnact.org.au. Some of you might know me from previous allied health engagements and may have my work business email. So I am the contact person for this program. However, I would request that anything that is tender related or related to your application for this email inbox to be used. Now, also take note of the submission deadline. And that's about it. So thank you very much. Our details are here. If you have any questions. I'm just going to stop sharing my screen. So I can see here in the chat. No questions as yet. Okay, so this is one question that we've received. Does the allied health provider need to be one provider? Simon, so I'm just wondering whether if do you mean that, for example, you're applying for accredited, like a dietitian services, and then one physio? Does it have to be one submission each? Not if that's what you mean. No, it doesn't necessarily have to be that way. So, for example, if there's a clinic that has all three, let's say a dietitian and podiatrist and physio or exercise physiologist, then that can be considered as one application. And in the form, you can specify which disciplines your company or your organization is is applying for. However, it could also be like solo practitioners who are not a part of a larger clinic, so they could be mobile providers, and they could apply as themselves. So yeah, does that answer your question? Okay, so would it need to be the same therapist throughout the length of the program? Now, this is a good question. We, I think, I mean, life happens. We have other programs wherein there have been change of practitioners within the same program. And if it's a change of therapist just because of time, let's say a particular clinic is providing podiatry services, and it could be that they have, let's say, 5 podiatrists on board, and for that particular day one couldn't attend and somebody else can come. I think that that's okay. So I feel that this is okay, but I'll ask Russ. This is all part of the co-design review, and I don't see why that should be a problem. But I think it's the organization that has to come into the co-design and come into the program. So if there are multiple people involved in the same position, um, then they would have to be a part of the discussion so that they can sort of change. Russ, sorry, I'll give the floor to you if you have a better answer to that question. Um, we can't hear Russ at the moment, so while we're waiting, so I'm just going to look at the new question. So it says here to confirm, for an example, we have an exercise physiologist and dietitian, but no podiatrist. Could we submit for an EP and dietitian, and then another podiatrist puts in an application? Yes, certainly. So you can in the EOI application form, you can tick which disciplines you are applying for, and then it's open to all the professions that we've specified in the EOI. So it can be a combination, like some podiatry clinics might have, let's say, only podiatrists. Some podiatry clinics might have podiatrists and dietitians, and some dietetic clinics might be working with exercise physiologists. So you just choose which ones that you can apply for. Okay, so I'm just reading Russ's message here. So Russ is our senior manager for primary care integration, and she is the project sponsor. Um, so she says that it shouldn't be a problem because the contract is with the company or the organization, and any allied health professional within the organization can provide the service. Thank you, Russ. We have another question here. Is CHN able to help facilitate discussions with podiatrists that are interested in the grant? Certainly. Well, at the moment, the EOI is open to all the disciplines, and I think we may have. I can't actually see the participants in the room, so I can see the number. I'll be able to see the names in a moment. But there there may be podiatrists in this session. So yeah. Will it be an exercise physiologist or physio or EP or physio? Okay, so this is a good question as well. This is something that's up for discussion. So what we really want to offer is exercise intervention. But it's open to both professions or both disciplines because yes, we understand that there are certain elements of exercise interventions that exercise physiologists are an expert of, and physiotherapy also covers exercise interventions for certain things. So we would like to see in the application basically why it's one or the other or why it should be both. And then this is up for discussion during the co-design. Because in terms of stakeholder consultation, what we found out is that both disciplines are needed, but it is the exercise intervention that we want to put into this program because, especially because of the group MBS items. So we would like to utilize the group MBS items, and hence it's not final. So at this moment, we just want to see the EOI, and at the stage of the request for proposal, I guess see how a clinic or organization sees that service being delivered, if it's delivered by one or the other or both. I hope that answers the question. Okay, so in terms of the EOI, so the EOI form only allows only requests for very brief information. So if you have further questions or questions that are not part of the EOI form, please do send it to the tenders inbox, and we will answer them straight away. I'm just wondering if I missed any questions. Okay. So it's 10:23. So we'll be requesting further details in the request for proposal stage. So as of this moment, so as it is an expression of interest, we would just like to know who the providers are that would like to participate in this program, and to see if the baseline requirements of the program can be met by the interested providers. But we will definitely go through the service delivery process at the RFP stage. If there are no more questions, I'll give you back the remaining 7 minutes of the morning of the 10 to 10:30 session. I think that's it. Right. Well, thank you so much for taking the time to join us today. And we do hope to see your expressions of interest. Thank you so much. Bye.